Hello. Hello, am I
Hello?
audible?
Yes.
Hello.
Hello.
Yeah, just yes. Yeah. Good evening to everyone. Just a minute. I will just log in with my ID.
Yeah. Who is Sam Vika Reddy?
Oh, it's someone else. Yeah, sorry.
Yeah. Sarah, I think we should write like we said a few months ago, a sort of general rules for DCB Academy. Okay, where we put,
Yes.
the gold standard behavior by everybody. So we decide which rules we should accept for the sake of the community. Okay, I think
Yes.
since now the number of physicians is increasing, we need to give some regulamentations, because otherwise it will be difficult to go on with the needed respect for everybody.
Yes, exactly. We will do this week.
Yeah. If you want just to draft something according to what we have said in terms of presence, time, and all of that, then I can revise it, please.
I will. Yeah.
All right, great.
Thank you.
Yes. Am I audible?
Yes.
Okay.
So today
shall
we
I
have
start?
a lesson from Dr. Krupal on the role of physiology adjuvants during angioplasty.
Yes. Thank you. Thank you for giving me the opportunity. I will share the screen.
Yeah, let me see if I can help you. Yes, now you can share your screen easily.
Is my screen visible?
Yes. What is this? Which one? Niagara, what?
Yes.
What is this?
Oh, this is Niagara Falls. Yeah, correct.
Okay.
So, today we are going to discuss about the role of physiology in coronary revascularization. And this is actually can be a part 2 of coronary revascularization along with physiology. Part 1 was by Dr. Bharat. He explained about FFR in ACS situation. Now this is for like other situations. So the format is kept same, like one case and relevant review of literature.
Okay.
So this case was a 59-year-old male patient who was a case of stable angina, who presented with chest pain and shortness of breath, which was increased over several weeks. He was a known case of diabetes and hypertension, and these were the medications he was on. This was his ECG, which was like quite normal. And this was his echo. That was also like normal systolic function. So the patient was not having any ACS, any LV dysfunction, and a stable but like low effort angina patient. This was right coronary artery. So we can see this patient has a positive treadmill test also. Then this RC had a mid segment severe stenosis, like a type A lesion, but almost 95% stenosis. This is another view for RCA. And this was the LAD. Now, LAD is like flowing well, but There was around 70 to 80% long segment disease, not very clear. It's like proximal mid part is narrowed, plus diagonal had disease. This was like spider view, aleocaudal view. L6 was non-dominant. This was aleocranial view. And some mild plaque in left main also. So this case was like ideal for.
Let me interrupt you, Krupal.
Yes.
1 second. I wanted to open a short discussion with the other fellows, at least those that are dealing with this type of lesions. Vakas, can you hear me?
Yeah, Professor. Yeah.
So we have a symptomatic patient with a stable angina, if I got it right. And this very critical, I would say, RCA lesion with who knows, diffuse disease in the LAD with some more stenosis in the middle part of it. So which would be your approach here?
Thank you very much, Mr. To me, this is there's no retrograde filling of the RCA. Definitely, RCA is a critical disease and it's a dominant vessel, and there is no cross filling from the left side, from the left system. So an LED is having a long diffuse segment, having a moderate diffuse disease, and diagonal is also having some moderate disease in the middle. I will go for FFR to the LED, no issue to me, because there is no retrograde filling for the RCA. If there is a retrograde filling for the RCA, then I will fix the RCA first and then go for the FFR for this LED and left main stem evaluation.
Okay, and what would you do for the RCA and for the left main? Would you do something?
RCA, this is I will first definitely intravascular imaging help in this case very well, but it looks to be a soft lesion and type A lesion. I will first pre-dilate it and then reassess if there is no flow limiting dissection. I will definitely opt for drug-coated balloon in this case in the RCA.
Okay, which is actually off-label, but okay.
Yeah, it is actually off-label. Yeah,
but otherwise, a short stent, I don't think would be a problem in that lesion.
Yeah.
So you would treat the RCA and do just physiology for the entire LAD. So this is what you would do. Okay.
Yeah, exactly.
Any other different approach? Bharat, Wojciech, who is here?
Yeah, I think looking at the left-sided system, there's eccentric plaque at the distal left main. So for me, I think it's important. This patient, PCI, I think that's or revascularization, there's two roles. Number one is there prognostic disease that we should consider revascularization? And number two is how can we revascularize to help with the symptoms? Patient clearly has symptoms. He's had a positive treadmill test, which I think is coming from the RCA being the most critical. But the left main, you do have some eccentric distal disease, and I'd like to interrogate that a bit further. We know coronary physiology in the distal left main or in the left main. There is some data, but it's not clear cut. We do use imaging criteria, I think. So maybe considering some sort of, physiology or image intracoronary imaging of the distal left main, just to make sure you've got a good size MLA. Either way, I think PCI for the right is okay, and then you can consider options for the left, whether it's PCI with drug-coated balloon plus minus stenting. I don't think the distal LAD is very graftable looking at it. So if it is a significant left system, I may consider a hybrid approach or full DCB approach to the left system.
Okay, so your approach would be the same for the RCA, so treating that with a stent or whatever, and then analyze a little bit further, either with physiology or imaging the left main.
Yeah.
To my knowledge, we have cutoff values for treating the left main according to IVO's criteria. not
Yeah.
for OCT, but we can assume that the size, the 6 millimeters square, could be
Agreed.
same.
Yeah.
Uh, For physiology, I'm not sure we have, a reliable amount
Yeah.
of data suggesting us to use it for a distal left main, if to treat it
Yeah.
or not.
Yeah.
Mm.
Yeah.
That's my only
I agree.
concern. But
Yeah. I agree. Yeah.
yeah,
And
okay, great. Please, sorry, didn't want to interrupt you.
Yeah, thank you for all the inputs.
Yeah, please.
So, yeah, we were thinking on the same way, like to do an physiological testing for LAD and then PTC to RCA. Because it is a triple vessel disease, we just explained to the patient also an option of bypass surgery because he was diabetic also. So now, like angiography has its own limitations. Angiography is basically a luminogram. We cannot see the vessel wall. So it's difficult to decide whether it's a diffuse disease or a focal disease. And in diffuse disease also, we may think that it's a 50% lesion, but it's actually more than that. Then also angiography depends on, it's a two-dimensional image. So it depends on the X-ray projections. Like depending on the X-ray projections, we may get different severity of stenosis. So it's very important to assess the physiology, and also the angiographic lesion may not correlate with the functional class. So it's very, very important to assess the physiology. Now, it's been already kind of proven through trials that FFR can help in assessment of functional assessment of the lesion, and also can help in making the clinical decision whether to stent or not. Then also another advantage of FFR is like we get a vessel-centric marker for myocardial ischemia. So a single vessel ischemia we can diagnose with FFR. So a little bit about basic of FFR. This was the result of FAME trial, which was like an initial trial with FFR. And it has shown that if compared to only angiography versus FFR guided PCI, the event rates were quite less in the FFR group, which is around 13% compared to 18% with angiography guided PCI only. So with a significant p-value. So how do we calculate the FFR? So FFR is based on the flow formula. Like basically we want to calculate the flow before and after the stenosis. And this formula is based on the pressure difference between the distal vessel and between the coronary artery and vein divided by resistance. So this is distal coronary artery and venous difference divided by resistance. And this whole thing is divided by proximal pressure minus coronary venous pressure divided by resistance. Now the coronary venous pressure is quite low, so we can cancel it because it's very minimal. For resistance to equalize before and after the stenosis, we have to induce hyperemia. So we induce hyperemia with adenosine, ATP, papaverine, and nicotinamide, but adenosine is most commonly used everywhere. So at resting phase, the flow is very less. And when we induce, when you give the adenosine IV or intracoronary, we achieve the hyperemia and the flow will be increased. So at that time of increased flow, to calculate the flow, we actually calculate the pressure, distal and proximal, as a surrogate marker for flow. So the simplistic formula for FFR is PD minus PA at hyperemia. Now, this is an example of such a situation, like if the distal pressure is 70 and proximal is considered 100, so PD minus PA, the FFR becomes 0.7. The cutoff value is 0.8. So it's a positive FFR. So in the wire, the pressure sensor will be here, like at the distal end of the wire. Now we give IV adenosine or intracoronary adenosine for hyperemia, and that itself has some side effects like decrease in blood pressure, or some patient may develop chest pain, especially asthmatic patient can develop spasm, bronchospasm. And out of that, hypertension is very important, and a lot of patients feel symptoms because of this hypertension. And this is a usual kind of a FFR what we see. So initially there will be, this is a resting calculation. There are two kind of overlapped waves. One is proximal aortic pressure and the one is distal to the lesion. And when we induce the hyperemia, the waveforms become separate. And then we can calculate the proximal and distal pressure like this. The proximal is 115 and distal is 88. So this FFR is 0.77, which is less than 0.80. So which is a positive FFR. Now, because of the side effects of adenosine and giving adenosine IV and waiting for its action, the whole thing will take a lot of time actually to prepare adenosine and give it. So to bypass that, there are some non-hyperemic parameters which can be used as a surrogate marker for FFR. These non-hyperemic parameters are either whole cycle or diastolic cycle parameters. They are either PD by PA ratio or RFR, that is resting full cycle ratio, or DFR, which is diastolic hyperemic free ratio, or IFR, this is instantaneous wave free ratio, or DPR, that is diastolic pressure ratio. These are the commonly used.
Sorry to interrupt you at this stage. I just want to ask one question at this stage.
Please, yeah.
When we read the literature, they are mostly written that before starting the FFR or IFR, just give intracoronary nitrates, and after that, when you want to induce ischemia, then, hyperemia, then start with the adenosine. So, what is the role of nitrates at this stage before starting the procedure?
Yes. Yeah. Shall I answer or?
Yeah.
Because
please,
experts
please
are.
go ahead.
Yeah, sure.
See, basically, there are, what is FFR is mainly for epicardial narrowing. Then there is a myocardial, or like small arterioles, which are responsible for resistance. And epicardium is like epicardial vessels are where the stenosis is. So when we give NTG, we relieve the spasm in the epicardial vessels. So NTG is for epicardial vessels, and adenosine is for the arterioles or microvasculature.
This is this is a clear explanation and the right one. They are two completely different drugs. Both of them can induce reduction in the blood pressure, but in the arteries, nitrates are working with GMP, and so its use is just to counteract eventual spasm. Okay, and we should do that always before any physiological assessment. Whereas adenosine is a completely different, is not working on the arteries, it's working on the microvasculature and is reducing and is creating the maximal hyperemia, eliminating any potential increase in the distal resistance of the distal bed. So we should use both of them for this type of assessments, unless the patient is particularly hypotensive and all of that.
Yeah, thank you.
Yes, yeah. Sir has said correctly. So I will go for the next slide. Now these the non-hyperemic parameters are mainly dependent on the waveforms. Like most of them calculate the pressure difference. There is main thing is to calculate the PDPA ratio. So they calculate the pressure difference during diastole. Those are called as DPR, IFR, and DFR. IFR is commonly used and kind of extensively studied in various trials. And there is an hypothesis that during the diastole, this is like a diacritic noise from here, the diastole starts. During the diastole, there is a specific time where the resistance is equal, irrespective of the degree of stenosis in the coronary artery. The resistance is equal before the stenosis and after the stenosis. And during this time, they calculate the PDPA ratio. It's the PDPA ratio at some different time, actually. And there is also called as RFR, which takes the average of the cycle. Then we have FFR, and the CFFR is like
as you
contrast
said,
induced,
as you said, the cutoff value, there was a gray zone at the beginning of this type of measurements until a few years ago. Now they selected a cutoff value of 0.89, below which the lesion is, significant. Should be considered significant unless we are dealing with the PDPA where the cutoff has been set at 0.91.
Yes, sir. So the diastolic parameters, like the non-hyperemic parameters are all almost equal, like their sensitivity, specificity, positivity value is almost equal. And this is ROC curve. Here, this curve is like it's the highest sensitivity and highest specificity. So all the diastolic parameters like DPR, DFR, and IFR and RFR has equal value. Like they are almost same, but FFR is slightly different. So these are all various parameters. So value for the diastolic parameters is 0.89, that is fixed. And value for FFR is 0.8. So these are like parameters we commonly use. CFFR is just we give contrast in case in place of adenosine. This is not commonly used. PDP is normal PDP ratio. So these are the more commonly used parameters like IFR and FFR.
Yeah.
Now these are the examples of like we get the same kind of waveform and the results are same. We just have to wait for the machine to calculate the pressure. And this is like RFR is 0.89, and this is like PDP ratio, and this is like DPR. Okay, so one is aortic waveform and one is distal waveform. Okay, so as I mentioned, IFR is most extensively studied and it measures the PDPA ratio at a specific time where which is called as wave-free period, and where the resistance is the least. Now, various validity trials have shown that IFR very well correlates with FFR, but it is not 1:1 ratio. It is not 100% correlation. The correlation is around 66%. And to calculate IFR, we have this formula, which is 0.21 plus 0.85 multiplied by FFR. So if it is FFR is 0.80, suppose, so it becomes around 67, 69, like, and we add 21 in that, it becomes 89. Now, most of the trials for FFR are like, for FFR, there are three main trials, DEFER, FAME, and FAME2. And for IFR, there are two main trials like DEFINE FLARE and IFR Swedhart trial. And these were quite extensive trials. They had around 1,000 to 1,200 patients in IFR FFR group. Swedhart also had 1,000 patients. And these were most defining trials. And on these trials, the guidelines were based. So DEFINE FLARE trial was a randomized, like international randomized controlled trial, which was conducted in 19 countries, quite extensive. Whereas IFR was only for 3 countries, 3 Nordic countries, and which is Sweden, Denmark, and Iceland. But it was like very well kind of a conducted trial. So they had DEFINE FLARE has 2,500 patients around, and this had 2,000 patients. So this was 1 year result of DEFINE FLARE and Swedhart trial. And we can see that there was no difference between the IFR group or FFR group, no difference between IFR group and FFR group. So with this trial, of 1 year trial, I think it was in 2018, because of these results, yeah, these are like secondary outcomes of DEFINE FLARE and Swedhart trials at 1 year. So no big difference between the two groups. Because of these results, these like IFR was included into the guidelines, and it is a class 1 indication to measure. Instead of FFR, we can use IFR as per the recent guidelines. Like these are 2021 guidelines.
Yeah.
And the cutoff for IFR is 0.89 and FFR is 0.8.
Okay.
So now recently, like in 2022, we have 5-year data. That was 1 year data. We have 5-year data of Swedhart trial. And again, the results are quite encouraging. There was no difference between the IFR group and FFR group. But for the DEFINE FLARE trial, the results are quite different. Like there were unexpected results. The MACE was okay. Like MACE was not significantly different between the two groups. The p-value was 0.07, like slightly higher than 0.05. But the overall MACE was higher in IFR group. This was the IFR group. So this was like
it's not
unexpected
significant.
result.
But it's not
Yeah.
it's not significant. So
Yeah,
It's a play of
next
chance.
one
This
was,
is a study was powered
Mm.
for the 1-year outcome, not for the 5-year outcome. So it
Yes.
says nothing.
Yeah. So there was a lot of criticism for this 5-year results. And this was not published anywhere. This was like just presented in EuroPCR, but not published in article, not published in journal. So we have the mortality data for the defined flare 5-year trial, and the mortality was significantly higher in IFR group. That was really unexpected and
This
surprising
is
also.
this is important. It's a 50% difference in mortality, plus 50% actually with the IFR.
Yeah, 1.5 times more than the FFR group. And the major reason was cardiovascular death. So this was not very much clear why it was there. Some kind of authors say that it's because of the COVID, and some authors say it's because of the design of the trial. They actually had like if the death is because of any unknown cause, then it is considered as cardiovascular cause. So it was not very clear.
You should also investigate. I don't have an answer to this question, if the populations that were enrolled in this trial as compared to the sweetheart were different or not. So that is another thing that you should look at to understand why there is this difference.
Yes. Then there was no difference in overall myocardial infarction and target means unplanned revascularization. So
this is
that was also surprising. So they said that most of the deaths were because of heart failure or unknown cause. So based on these two trials, there was a meta-analysis published in European Heart Journal.
With two trials?
Meta-analysis
with two trials? Wow.
Yeah, this was the two trials.
Wonderful.
It's like study level meta-analysis of DEFINE and IFR sweetheart trial.
A study level meta-analysis. They publish it in a European Heart Journal. Wow. I'm really surprised.
Yes.
Fast track.
And this was like 2023 August, like last year, like a few months back, like 8-9 months back.
Yeah, accepted after 1 month. Incredible.
And they found that IFR arm had more mortality. So it's all related to defined flare results actually.
But how can you say that? This is not a patient level meta-analysis. How can you say that IFR is associated with more mortality? You put two different studies. You just can read the two studies. You can see that in one, FFR, there is no difference. With IFR, yes. So what is the add-on of this study on the topic?
It is not very much clear till now whether we will be able to replace IFR completely or not, like FFR completely with IFR. And these were like quite recent things, like maybe in future we will
but my criticism was on the design of the study, not on the IFR itself.
Yes.
Okay, let's move on.
And this the same study was also like published in, this is like JACC journal, like online it is published, like American College of Cardiology journal. And they just mentioned the summary of that article, the same article, European Heart Journal. And here they mentioned that at this time, FFR guided revascularization should be the preferred strategy when intracoronary pressure measurement is indicated. So there was still
I'm
some
not sure,
I'm
not sure about this because, I would like to know your opinion, but this study was a study powered for a 1-year outcome and 1-year comparison between FFR and IFR. This is the first point. The second point is that at 5 years, there is an increase in cardiac mortality, but no differences in MI and target lesion revascularization. So how can you say that? So it's this is not science, in my opinion.
Also, I have got a point. I've got a comment to make. I think we need to look into this in more detail because I agree with Bernardo. It doesn't make any sense because how can you have a higher mortality in IFR unless you are differing patients in a wrong way because of the wrong values obtained from the IFR? I don't know.
that you are basically not treating the patient based on the IFR recording and medical management. Patient come with a cardiac death or an MI, then I can understand, but this doesn't make sense.
Yes, I completely agree. But probably when there is some confusion, probably we should be relying more on FFR when there is some discrepancy between IFR and FFR. So better to rely more on.
Yeah, but the Sweetheart trial led to different conclusions, no?
Yes. That was like non-inferiority trial, not about superiority. Yeah.
Yeah, but also this was a non-inferiority trial. In the design of the trial, this was a non-inferiority trial.
Non-inferiority.
And by chance,
I think they both were non-inferiority trials. They both basically
both
that you could use IFR.
Exactly. They are both non-inferiority trials. So how can you say that?
Yeah,
in my practice, practically, I somehow rely less on the IFR because there have been times where you have 0.95 and then you do FFR, it is positive, and patient has a good symptom. So we rely more on FFR. I kind of agree with that article, but I don't know what others feel. I don't know what Bernardo and others feel about the FFR and IFR discrepancy.
Yes. Yeah.
Well,
there
now
usually there is one more.
Yes, please go ahead.
Sir, yeah, there is one more registry that is more kind of assuring. Yeah, you can say, sir. Yeah, what do you say?
No. I was just replying to Sandeep that there is still a gray zone. When we use well, I prefer to use adenosine, but only because for two reasons. One is that I am an imaging guy, so I usually use imaging. I like to see the things. We have clear cutoffs and studies and all of that. And we have a clear correlation with the hard endpoints, from several data coming out in the last 2 years mostly. And then, okay, I use physiology, of course. If I have a clear information on the PDA or IFR, that's enough for me. If the measurement goes into what was the gray zone, I usually do adenosine, because I agree that unless it is frankly positive, the PDPA or the IFR or whatever, I still have some doubts, and so I do adenosine.
Yes, sir.
I have one question at this stage. Which one is more you are relying on? Because especially I mostly use imaging catheter like IVUS catheter to look and calculate mid-luminal area, MLA. But if it is significant, then I think, or it is in between gray zone. Let's suppose we are doing IVUS in the epicardial coronary artery and it is in between 4 to 6 MLAs, in between 4 to 6. So would you like to go for FFR in this stage, or you will fix it? What is your thoughts about it?
Well, usually if you collect the symptoms, the data deriving from symptoms, then angiography plus imaging, I would say that in 98 or 97% of the cases, you can take a final decision. Of course, it's also according to your experience, but the symptoms are very important for the patient, because we know that mostly in elective cases, angioplasty is not going to change the survival of the patient. Okay, so if the patient is symptomatic, we have a quite clear angiography and a quite clear imaging, that's enough for me. Adding another information with physiology can increase the cost without adding. Can you mute? I don't know who is speaking now. Okay, without adding a clear benefit to the final decision. And I have to add another thing. Usually physicians give a 70 or a 90 or 100 micrograms for determining the complete distal hyperemia of adenosine. But in my experience, if I go for higher dosages, I can get different values. Okay, so for example, if I go with a 100 and I have a 0.82, and if I go with the 200 micrograms or 300 micrograms, this usually comes below 0.8. So all of that is saying that since you use adenosine to get not to get a different value, but to get the complete hyperemia, you have to eliminate any resistance in a very distal belt, vascular belt. This rendered this technique not really reliable, but this is not science. I'm just speaking about my experience and my perception of this technology, which is important, but not completely reliable so far in 2024. Again, I repeat, in my opinion.
Yeah. Okay.
Yeah, I agree. That's a very good point. Sometimes you just have to give higher and higher until you see a block. So the way I kind of think about it is you get a short, prolongation, a block, and that's when you've achieved hyperemia. So 100, 200 usually may not be enough if you're doing intracoronary. Intravascular is more reproducible.
Yeah.
So if you do the 140 mics per kilogram or the 180 mics per kilogram, I think it's more reproducible. But intracoronary, yeah, it's so variable.
Yeah.
Sometimes 100 is enough. Sometimes you need 400.
Yeah.
Understand.
Yeah, great.
Yes. Yeah. To reduce this confusion, actually there is one more data available from Swedheart National Registry. Now this is also not a published trial or published data, but it's presented in some of the kind of conferences, and it's from the registry, not a trial. It's not 1:1 trial. So here they kind of studied in 42,000 patients. It's a very high number, but most of them are in FFR, like 34,000 patients are in FFR group and around 8,500 in IFR group. So here they found that there was no kind of a difference between the primary outcome as well as the secondary outcomes. And what they mentioned is like the observed difference in mortality between the IFR and FFR among treated patients in defined flare could not be verified in the large nationwide real-world all-comers registry analysis.
Yeah,
So
the big limitation of this type of analysis, if you compare it to a randomized clinical trial, because if you don't have a randomized clinical trial, you can do whatever you want. We are doing with DCB Academy a lot of sub-analysis of Eastbourne, okay, because we don't have so big clinical trials. But if you have a randomized clinical trial and you compare it with these huge numbers, you will always have a selection bias of patients. So I'm quite sure that many of these patients that were treated with IFR, that were analyzed with the IFR, probably had a contraindication for using adenosine. So there is a super selection of the patient. So these data are not really highly scientific, in my opinion.
Yes, sir. So now the main our case was which is like a long disease in the LAD. So
yeah,
what is the difference between FFR and IFR in serial lesion or a diffuse disease?
Yeah.
So diffuse disease means generally the definition wise it is only more than 20 mm, but any disease more than 30-40 mm is considered as diffuse disease. The problem of diffuse disease is the calculation of FFR becomes very complex in such situation. And what we do generally is we do the pullback maneuver with the FFR value. And with pullback maneuver, we can decide the pattern of the disease, whether it's a focal or diffuse. And this pattern can decide whether we should go ahead with revascularization or not. So this is one of the study which has shown that if we use FFR guided pullback in diffuse disease patients, there can be 36% chance of reclassification. So anatomy-wise, this angiography-wise, what they thought was 62% focal lesion, but after the pullback maneuver, FFR-guided pullback maneuver, there were only the patients were reclassified and classified as 50% were classified as focal, and whereas other patients were classified as diffuse and combined lesion. But it was a small study. They just did only in 159 vessels, 159 patients.
Okay.
Then, as we have seen now, how the FFR is calculated, this single lesion, there is no problem. But if there are two lesions, which are kind of apart from each other, these two lesions can influence each other. Because of the proximal lesion, there cannot be increased flow for the distal lesion. And because of the distal lesion, there cannot be proper hyperemia for the proximal lesion. So calculating FFR here for the proximal lesion is quite difficult. the calculation, the mathematical formula is quite complex and may not be always correct. But the overall distal FFR can be accurate. But here in between the two lesions, we cannot decide. In such situation, we have to stent any one lesion, which we feel that this is like kind of a severe, and see the FFR again, and again induce the adenosine and all, and again induce the hyperemia. So that can be quite lengthy, and also kind of a patient will have discomfort because of adenosine twice and thrice. So further, in case of diffuse disease, this calculation becomes further complicated. And diffuse disease can be just diffuse disease, or there can be a focal lesion along with the diffuse disease, and this focal lesion may be significant along with the diffuse disease. So it is very difficult to say with FFR only lesion to be treated or not. So there are like various studies. I have kind of mentioned 4 studies which have shown that non-hyperemic parameters are much helpful in diagnosing the physiological significance of the lesion when there are serial lesions or if there is a diffuse disease. So with hyperemia, the crosstalk between the 2 lesions will get exaggerated, and only non-hyperemic parameters are not associated with the hyperemia, so that can determine whether the lesion is significant or not. And it is more accurate than FFR. There are 2 registry data also in that. One is GIFT registry and one is IFR gradient registry. And they compared with FFR and they found that the results are much better with IFR. Like the prediction after angioplasty is much better with IFR. Now this is like, we have actually 2 cath labs. This is in one cath lab, we have the co-registration of IFR. So we can, this is real patients, like these are real patients. We can actually calculate the IFR at each point. We can co-register. This is a Volcano device. We can co-register and calculate the IFR at each point. And the dot, the yellow dot, is for the jump in the IFR pressure. So here it is like jump for 0.01 parameter, like 0.01 pressure. So the higher the jump, that means that place is more significant. So here the 2 dots is little significant, but overall this was negative IFR. This was also same. So this is the advantage of IFR. We can calculate the like physiological level at any level, like any place of the lesion along the whole length of the vessel. This was like an article which has shown the similar thing. And here each red dot is equal to 0.03 jump in the
I think
IFR
you are running a little bit late. So if you have other concept to express, please jump there.
Yeah, this is like our case.
Okay.
So we did the pullback. This is a manual pullback. And this case was done actually 1 year back. So this is very simple, like it's around 1 to 2 mm per second. Over 20 to 30 seconds, we have to do the pullback, and we can see if the pressure recording is good, we can slowly pull it out.
Yeah, we cannot
this was
see
the
pressure
IFR result.
Okay.
Yeah, here. This is the IFR actual result which we have given to the patient.
Okay.
Yeah. So this is like aortic pressure, and this is like distal pressure. And whenever this is positive, we can see that ventricularization of the pressure waveforms. So it's quite significantly positive, 0.50 only, 0.58 only.
Yeah.
So we did this is like just one single this one, and this is like pullback. So we can see the pullback waveform.
1,
it's
2,
a diffuse
3,
disease.
2, 3, 4 jumps, 5 jumps.
Yeah, but very less, like not only 0.1 jump, and not very significant. And whole length, like over the whole length there was. So it's like a diffuse disease. So basically, generally diffuse disease, we should not go for PCI, but we will see like. So
yeah, but what about the left main? What about the left main?
Left main, there was no significant kind of a increase in IFR.
So you did an analysis just distal to the left main?
Yes. We did that also.
Okay, and it was negative.
Yeah. I don't have the whole. Yeah. Yes, sir. It was negative.
No, because I can see a jump very proximal, but we cannot see if it's significant or not. But you did the measurement just distal to the left main, and it was negative, if I understand well.
It was negative. Yes, sir. Yes,
Okay.
it was not less than 0.89. It was coming around 0.89. So we checked the left main was also not
8.9 is positive.
like less than 0.89 is like
More than 0.89.
Yeah. So
More than 0.89.
Yeah, we
Huh?
actually we checked it 2-3 times. So every time it was not coming
Yeah, but
positive.
so no, I wanted to understand because there was this lesion in the left main. We have said already that physiological analysis of distal left main is not completely reliable. We have paucity of data for that. But since you did this measurement with this proximal jump, it is important to understand if you correctly assessed there the jump in the left main and if it was more than, I would say, 0.90 and above.
Yes, like this was like we did the case 1 year back, and as far as I remember, there was no.
Okay. So you
elevation
judge that the left main not significant, at least from the physiological point of view. Okay, that's fine.
Yes.
So what did you do?
One of the things, sorry to interrupt, one of the things you can
Please.
do is just pass the wire into the circumflex and do the pullback from the circumflex. Because the LAD has disease, and if the circumflex doesn't have disease, then all the drop in the pressure will be due to the left main. So one
Yes.
thing you can do is to double check, is to just, that's what I do sometimes. If I'm not very sure, I just pass it down the circumflex and do a quick pullback and see whether you get your dots, in the left main itself. So that's one other little thing you can
The only
do.
thing, the only thing is that sometimes the plaque distribution in the distal left main
Extends
is not
into
only
the
distal. Yeah, exactly. It extends directly more to the LAD. So the length of the lesion is longer, left main versus LAD instead of left main versus circ. So this can be a little bit tricky. So this is why I say let's do IVUS or OCT for left main. We have a lot of data showing which is the cutoff for treatment. But okay.
Yeah.
So please conclude this case. You stimulated a lot of discussion. You did a great job, Rupa.
Thank you, sir. So this is another kind of a review article, and which has given how to treat about the focal lesion and serial lesions and diffuse disease. So in case of diffuse disease, actually the functional improvement may not be great even after PCI, and we should avoid overstenting. And that's what we tried in this case. We just did balloon dilatation of the proximal and mid part of the LAD. Initially with NC quantum and then with Sequenio DCB balloon. And
so you did the contrary. You did the contrary of what this consensus document is stating, because you said there is a diffuse disease. I could see some jumps. I agree that they were small jumps, not big jumps. Yeah. But then you said, okay, we have diffuse disease. With diffuse disease, we should not do angioplasty, but you did angioplasty actually. Yeah. Okay.
No, we have to accept the suboptimal result. Avoid overstenting. Yeah. We can go for the PCI.
But let me understand. So you had already treated the RCA, or
no?
Not?
We treated RCA also
before.
Yeah. So no, just after this. The main purpose of just after this. The main thing was like the patient is going to have the PCI for RCA, and we put a stent for RCA after this. So it was like not to complicate it more, because we wanted to have a proper flow in LAD and see the result of DCB further, like on follow-up, whether it will modify the plaque. And because this is the diffuse disease, CABG also will have not a great result.
Yeah, but just to underline this, you said what the guidelines and the consensus documents are saying, and you did the contrary, but which is okay. For me, it's not a problem. It's something that you can do for the sake of the patient. But in the end, after this IFR, which was positive, probably due to a diffuse disease, you used the DCB for the left main, because if I saw it clearly, you also, here the stenosis is not there, and it's much less. So DCB for the left main and the proximal LAD, but not for the middle AD, if I understand it well.
So, we also did for middle AD, but there was not much great result, kind of.
Because
then,
the inflation, the balloon that you put was not in the middle AD. It was just distal left main and proximal LAD. Probably you didn't
I
put
just
the
showed
images of that.
Yeah, this one, I didn't put the images of that.
Yeah, it's important.
But like
when you describe a DCB angioplasty, to put all of the iconography, it's important for us to see where exactly you deliver the drug, because a stent you can see often, not always, but often. A DCB you cannot know.
Yeah. So in this case, actually, we were thinking to go like more with the extensive kind of a dissection further with balloon and all, increasing the size of the balloon. But main thing was the main culprit lesion was like RCA, and main thing was to treat the RCA and then see this. We can follow him up if there is any plaque modification with DCB. And in the next time we can further do an extensive, because we are like for RCA. There was a very tight stenosis and we dilated and there was significant recoil. So we went for stent. So like we didn't want to have any problem with RCA stent, like stopping any antiplatelet or anything and having any bigger dissection in LAD. So this was like, that's why we treated with DCB only.
Yeah. Okay. So this is the final one.
Yeah. And in this one, like we can do PCI for diffuse disease, but we have to avoid the overstenting. Like,
yeah, okay, but you have to be sure. You have to be sure. You cannot do a half angioplasty. Okay, if you decide to treat a patient, you have to treat that patient with whatever you have in order to have an improvement. So you have to decide which is upfront, which is the improvement you want. Do you want only an improvement in the lumen? Do you want an improvement in physiology or whatever? Do you want just an improvement in symptoms? So this is the question that you should pose yourself. So this is why in this specific case, me personally, I would have done the RCA and then I would have followed up the patient clinically to see if he or she had an improvement in the symptoms. If not, or if the improvement was not clear, or if there was a test positive, then I would have managed the left coronary system.
Yes, yeah, I think that is a very good approach. The other thing was like, yeah, this could be a very like a potential indication for DCB to use in diffuse disease. So I'm just quoting this review article. This was just like 1 month back published, like in the month of May. And it was by the, like most of the authors are from USA. So where the DCB use is less.
Yeah, but they don't do angioplasty with DCB. So who is these guys?
Yeah.
I know Robert Ye is the PI of the agent trial where they use DCB for ISR. Ayai Kirtane is dealing with a small vessel disease study there. So, you know, the experience with DCB is not in the US so far. Experience with DCB is in Europe and Asia.
Yes.
Yeah.
And this was just like published 1 month back. I couldn't get the.
Yeah, no, I know. I saw it. I saw it. It made me laugh.
Krupal, at this stage, have you performed again IFR after the procedure? Is there any change in the result?
It was positive. It was quite low. I think 0.7 something. It was not coming high.
Yeah. Okay. I see.
Krupal, it's nice. Sorry, I'm just laughing.
I want to be honest.
This is just for discussion. I just want to. Is there any change in result dramatically or?
That's an important point. So
really
can I label this? Krupal, you invented a new therapy, which is half angioplasty. You did a half angioplasty. I'm joking. Sorry, okay. I don't want to be disruptive, but just joking.
Just for discussion, discussion.
Yeah. I'm not, I'm a kind person, but I like to laugh. Yeah.
So this was like here they mentioned that DCB can be used in diabetic patient with diffuse disease to minimize the use of long stent. So
yeah, we will see. But okay, for diabetic patients, diffuse disease, the
put the wire down. Put the wire down.
Is very important. Put the wire on because the patient has a STEMI, I think, in Sandeep's. But the role of DCB for diabetic patient is still to be proven. We have some sub-analysis. We have, I think I participated to a meta-analysis on diabetic patients treated with DCB, but there are no randomized data. So the potentiality for DCB is there, but we need to have data in this setting.
Yeah, and just wanted to quote like one of the trial, like Picoleto trial, one like 3 or 4 has small vessels with DCB. Like I think it's like equal to this diffuse DCB, like small vessel use of DCB in small vessels.
No, Picoleto 1 and 2 are small vessels, up to 2.75. Picoleto 3, 4, and 5 also accept large vessels.
Yeah, yes. So going further, now we discussed about the wire-based FFR, but there are some angio-based FFR also. Most importantly, QFR. This is like total computational calculation with only angiographic views without putting any wire. We can have the data. This is like a separate software we have to attach in any cath lab. We can attach. We don't have it in our cath lab at present. So we get such data like the green, the blue one is like normal FFR, and the more red one and yellow one is like more FFR, less FFR. And there are various kind of companies which help, like which make this software, and we can use them along with our cath lab machine, and we can directly calculate the QFR. It's very helpful, and very many centers.
Yeah, we did a study. We presented at EuroPCR at Picoleto 6. We used the MUFR for this study.
Yes, yeah. Now there are already validated trials already completed. Now there are no non-inferiority trials going on, and these are many non-inferiority trials. Once they show that it's non-inferior, then it will be like probably in future everybody will be using QFR more. If the non-inferiority is proved, because it is without wire, it's only angio-based FFR.
Okay.
Then this is like a summary of all kind of a physiological tests which we can do. One is like non-hyperemic parameters, then FFR. Then there is another index called as PPG index, that is pressure pullback pressure gradient index, and then QFR. And there are various kind of a levels beyond which we can consider as a significant lesion. This QFR is actually, it can give a virtual pullback also. Apart from calculating FFR and focal lesion, we can have a virtual pullback parameters also with QFR. This is like virtual pullback. Then now the further new things which are coming is like IVUS based FFR, which is called as UFR, ultrasonic flow ratio. And then OCT based FFR, which is called as VOFR. Okay, these are all in the validity stage.
Yeah.
So they may also come up in future. Yeah, that's it. Like this is for the case. I have 2-3 slides more.
Okay.
Shall I?
No, yeah, but we don't have the time. It's already 6. This is a very big topic.
Yes.
So it's normal if you went a little bit long. I always ask the presenters to stay within the 15 to 20 minutes in order to have more time for discussion. But today we had a very nice discussion. I don't know if Sandeep, Bharat, or Vakas, or Jacinth, or Sarah would say something. Wojciech.
Yeah, it's a very good presentation. I enjoyed a lot, and a lot of new things I came to know.
Yeah.
Thank you. Thank you.
If you have any other points, no specific points apart from thanking.
Yeah, no any other. But nowadays, most of the time, companies are making new software like a MUFR, and they are working on QFR and MUFR. So this is the new technology we'll see in the future.
All right.
Yeah, I think there is a new system called CathWorks from Medtronic, which I saw at the PCR, which is like a AI-based FFR calculation, or QFR they call. But the good thing about it is it's there's another one called Medis, which again I've seen in some centers which is an operator-based calculation. So even if you Like you can make the ejection fraction and an echo from 55 to 65% by just moving the cursor by 2 millimeter. So same thing with the other ones. I feel it's all operator dependent, whereas the Medis is more of AI based, which is more accurate. But again, it's not very well validated from my understanding. So I think it's still early days.
Yeah, there are studies with some hundreds of patients. One is 2,000 patients that, but you know, validating these studies with the physiology is quite easy. They use quite wide confidence intervals, and their results is really debatable. But they can give you a good information. The advantage of this is that first, you don't have to place a wire, and second, you can do it after you have done your PCI. So you do your PCI, and then you assess the other vessel later, the day after, with your colleague. So you do it together. So there are some potential advantages. But
yes, I agree.
In the end, yeah, in the end, I agree with you that physiology has been studied in tens of studies with hard clinical endpoints, very well done studies. Some of them with doubts, living doubts, but at least we know when to use it. A widespread application of μFR or QFR just instead of invasive measurements, maybe, as you said, is really too early to apply that.
There is a
right.
notion. This is a very historical thing. If you want to stent, use an IVUS. If you don't want to stent, use an FFR.
that's I've used it many times. Yeah, this is why I like imaging, but not with stent. If you want to do angioplasty, not necessarily.
Exactly. If you want to do something, just do it.
Yeah. Very nice. So I enjoyed a lot of time with you as usual. Next lesson, who's gonna help me, will be critical thinking. Next Tuesday.
Yes.
Today
yes.
we don't have the time to do an update on the papers. Just very fast, I can tell you my update, which is I revised the meta-analysis by Amanda, and I sent it back to her. And I revised the consensus document by Bharat, sent him.
Yeah.
And then I did another thing, I don't remember. I did three things. Eastbourne Geographic. I finished
Eastbourne,
also
yeah.
Eastbourne Geographic. Yeah. You can send it to the journal.
Yeah.
We received an email today by CCI. They asked for some revision of the paper by Wojciech and Sylvia. On the comparison between DCB and DES in de novo complex lesions. So things are moving. Huh?
Yes, thank you very much.
Thank you very much, Doctor.
Thank you.
Thank you, everyone.
Thank you very much.
Thank you all.
Thank you, sir.
Have a nice day.
Thank you, sir.
Bye-bye.
Thank you.
Bye-bye.